Welcome back to the deep dive. Today, we are digging into a topic that sits right at the intersection of, well, hope, biology, and a fair amount of bureaucratic frustration.
Yeah, we're talking about the body's own internal repair kit.
The idea that you can take your own blood, run it through a machine, and use it to heal injuries that just won't heal on their own.
It's a field called orthobiologics, and it is absolutely exploding right now.
We are talking, of course, about PRP platelet-rich plasma, and we're diving in today for a specific listener, Elton, who sent us a really detailed and, frankly, a very relatable medical puzzle.
Hello, Elton, and thank you for giving us so much detail. It really helps us focus this deep dive.
So let's paint the picture. Elton is 71 years old. He's a stroke survivor, which is a crucial piece of context we're going to come back to.
A very crucial piece.
He's managing his cholesterol with Crestor and Repatha, and most importantly for today's discussion, he is on Eliquis.
Which is an anticoagulant,
Mm-hmm.
a blood thinner. And that one medication changes the entire calculus of the procedure he's asking about.
Exactly. So here's the situation. Elton developed some hip pain. His physical therapist suggested an ultrasound, and that scan found a tear in the gluteus medius. Now, for those of us who aren't anatomists, where exactly is that?
Okay, so think of the muscle on the side of your hip. The gluteus medius is what keeps your pelvis level when you walk.
Ah,
Every time you lift one leg to take a step, that muscle has to fire. If it's torn, your hip can drop on the opposite side. It's a major stabilizer.
so for a 71-year-old, this is not just my hip hurts, this is a stability issue, it's a balance issue.
It's a huge deal. And tendons in that area, they just have a really poor blood supply, so they don't heal well on their own.
Which brings us to the treatment. Elton is undergoing PRP therapy. They're spinning his blood and injecting it right into that tear. And he has two massive questions for us.
Mhm.
First, what does the actual research say about this procedure for his specific injury? And second, the one that drives everyone crazy, why won't Medicare pay for it?
Both excellent questions. One's about biology, the other's about bureaucracy.
Before we jump in, our standard disclaimer. We are analyzing the research we've been provided. We are not doctors.
And this is so, so important today. Elton, you're a stroke survivor on a potent blood thinner. Nothing we say here replaces the advice of your actual medical team.
Right. We're here to help you understand the data so you can have a better, more informed conversation with them. And I'll be narrating this, so if you have your screens off, you can follow along.
Okay, so let's start with the basics. What is PRP?
I think most people know platelets as the things that, stop you from bleeding when you get a cut.
That's their day job. They form a clot. But they have a night job, too. Platelets are basically little backpacks filled with growth factors.
What kind of growth factors are we talking about?
Well, you've got proteins like PDGF, platelet-derived growth factor, and VEGF, which helps build new blood vessels. When a platelet gets activated, it basically unzips that backpack and danks all those proteins into the tissue.
And what did those proteins do to a torn tendon?
They're like a megaphone. They send out a signal to the body's repair crew, your stem cells, your fibroblasts, and they say, hey, we've got an injury here, get to work, start building new collagen.
Okay, I get the logic. A tendon, like the gluteus medius, is like a plant in really bad soil. Not enough blood flow. PRP is like trucking in a load of super concentrated fertilizer.
But that's a perfect analogy.
Mm-hmm.
The process itself is pretty simple. They draw your blood, maybe 30 to 60 cc's, and put it in a centrifuge.
The spin cycle.
Right. It spins really fast and separates everything by density. The heavy red blood cells sink to the bottom. We don't want those. The goal is to isolate that plasma layer and get a solution that has 3 to 5 times the normal concentration of platelets.
It sounds straightforward, but looking at the research, it seems like PRP isn't just one thing. There's this big debate about the ingredients, right? Specifically about white blood cells.
This is a huge point of confusion, even for clinicians. It's the leukocyte debate. Some PRP is leukocyte-rich, they keep the white blood cells in. Others are leukocyte-poor, they filter them out.
Why would you want white blood cells in there? Don't they just cause inflammation?
They do. They're the primary drivers of inflammation. But here's the biological tug-of-war. Some researchers believe you need that inflammation to kickstart the healing process. You're basically creating a controlled acute injury to wake the tissue up.
But inflammation hurts.
It does. And it can cause scarring. So the other camp argues that for tendons especially, you should get rid of the white blood cells to avoid that and just let the growth factors do their job. There's just no standard recipe.
Which brings us right to Elton's first question. Does it actually work? I mean, if the recipe is different everywhere you go, how can you even compare the data?
That variability makes the data really messy. But we do have some signals. A lot of the best data we have is actually for knee osteoarthritis, not for hip tendons.
Okay, let's start there. If Elton had a bad knee instead of a hip, what would we tell him?
For knees, the data is reasonably positive for symptoms. The AAOS guidelines show that compared to a placebo, like a saltwater injection, PRP does provide a statistically significant reduction in pain and improves function. Patients report feeling better.
But feeling better isn't the same as healing, right? Does it regrow the cartilage?
No, that's the key. The evidence does not show that PRP regrows a new knee. It seems to improve the environment, it reduces inflammation, maybe helps with lubrication, but it's not structurally rebuilding the joint.
Okay, so let's pivot back to Elton's hip, the gluteus medius tear.
Here, the data is more mixed. We often have to look at data for the rotator cuff and the shoulder as a stand-in, because it's a very similar type of tissue and injury.
People call the gluteus medius the rotator cuff of the hip, I've heard.
Exactly. And the verdict there is, I'd call it cautiously optimistic. Early reviews, like a big one from Cochrane in 2014, were pretty skeptical. But more recent studies from 2021 and 2022, they're showing that for partial tears or chronic tendinopathy, it can be pretty effective. One review showed almost an 80% positive rating from patients at the 6-month mark.
That sounds pretty good. But you emphasize the word partial. That feels like a big catch.
It's a huge catch. If Elton has a full thickness tear, the tendon is snapped completely and pulled away from the bone, PRP isn't going to glue it back together.
Right. It can't bridge a gap.
No. It works best when the fibers are still connected, but are frayed and degenerated. So if his ultrasound showed a massive retraction, this might not do much. If it's more of a fraying, then the data suggests it's worth a shot.
Okay, but now we have to talk about the elephant in the room. Or the medication in his bloodstream. Elton is on Eliquis.
This is where we have to get really specific. This isn't just about general safety. It's about a very sophisticated biochemical problem.
A problem of trying to use a clotting therapy on someone taking anti-clotting medication.
Precisely. Remember how I said the platelets need to degranulate to release their growth factors?
They have to unzip the backpack?
Right. And the signal to unzip that backpack is usually part of the clotting cascade. An enzyme called thrombin is a key trigger. Well, Eliquis works by blocking a step that's needed to create thrombin.
So, hang on. If his medication stops thrombin from being made, and thrombin is the key that unlocks the backpack, does the PRP even work? Do the growth factors ever get released?
That is the million-dollar question. And it's a critical one. Some protocols try to get around this by adding an activator, like calcium chloride, directly into the syringe to manually force the platelets to open up.
So they hotwire it.
They hotwired it, yeah. If his doctor isn't doing that, and is just relying on Elton's own body to activate the platelets, the Eliquis could seriously blunt the effect of the whole procedure.
Wow. So it's not just a safety risk, it's an efficacy risk.
Exactly. And let's not downplay the safety. The UW Sports Medicine Guidelines we looked at explicitly list bleeding as a risk. Sticking a needle deep into the hip of someone on a strong blood thinner carries a real risk of causing a hematoma.
Which is why they have to use ultrasound guidance. It's non-negotiable. They have to see exactly where that needle is going to avoid hitting a blood vessel. It is a very, very delicate balance for a stroke survivor.
So it sounds like Elton needs to ask his doctor, hey, since I'm on Eliquis, how are we activating the platelets in my PRP?
That would be a very, very smart question to ask.
Okay, let's tackle the second part of Elton's mission, the money. Why won't Medicare pay for it?
It feels like such a slap in the face. You're 71, you've paid into the system your whole life, you have a clear injury on an ultrasound, and they just say no.
Is it simply because it's expensive?
No, Medicare covers lots of expensive things. It all comes down to the regulatory definition of what PRP even is. This is what I call the PRP paradox.
Okay, break that down for us.
The FDA regulates two main things: medical devices and drugs. The centrifuge, the machine that spins the blood, is an FDA-cleared device.
So the blender is legal. The blender is legal, yes. But the smoothie, the PRP itself that they inject, is not an FDA-approved drug. Because it comes from your own body, a pharmaceutical company didn't make it. The FDA has not officially stamped it as safe and effective for gluteus medius tears.
And without that official stamp...
Without that stamp, and because every clinic prepares it a little differently, Medicare and other insurers classify it as experimental and investigational.
Experimental? That just sounds awful to a patient.
It does. But in insurance speak, all that means is There is not enough standardized, high-quality evidence to prove this is a reasonable and necessary treatment.
So the lack of a standard recipe we talked about earlier is the direct reason Elton has to pay out of pocket.
Precisely. Until the medical community can agree on a single reproducible protocol, this concentration, prepared this way for this injury, insurers will just keep their wallet shut. It's considered off-label use.
That's frustrating, but at least it explains the logic. Okay, finally, let's talk about the recovery. What do the next few weeks actually look like for him?
This is so important. We have to set realistic expectations. PRP almost always hurts before it helps,
Why is that?
because we are literally injecting inflammatory signals into the tissue. We're trying to provoke a healing response. The first few days are all about protection and pain control.
And normally, if my hip was flaring up, I'd reach for an ibuprofen, an Advil, or an Alev.
And that is the one thing he absolutely cannot do. NSAIs work by blocking inflammation. If you take them, you are effectively canceling out the very treatment you just paid hundreds or thousands of dollars for.
So he has to ride out that initial pain flare without the standard go-to painkillers. That's a big ask for a 71-year-old.
It's a huge ask. Tylenol is usually okay, but that first week can be really tough, especially for someone who may already have mobility and balance challenges from a stroke. He might feel significantly worse before he starts to feel better.
And the timeline for improvement, are we talking days?
No, think weeks to months. Rebuilding collagen is a slow biological process. The real strengthening in physical therapy often doesn't even start until 2 months after the shot. It is not a quick fix like a cortisone injection.
Okay, let's bring this all home for Elton. Let's summarize the mission.
On the research front, it seems like a reasonable option for a partial tear with a good chance of reducing his pain and improving his function, but probably not a complete structural fix.
And the money question.
It's unpaid because it's considered off-label and experimental by Medicare, and that's all due to the lack of a standardized recipe.
And the safety, specifically for him as a stroke survivor on Eliquis.
That is the biggest red flag. The conversation has to be about both the bleeding risk at the injection site and the very real possibility that the Eliquis could be interfering with the therapy's effectiveness.
It really does feel like this whole field is the Wild West right now. We have this amazing technology to use our own bodies to heal, but the rules and the science haven't quite caught up yet.
It's a growing pain of modern medicine. We're trying to shift from the one-pill-fits-all model to a your biology is the drug model, but our systems, insurance, the FDA, they're all built for that old model.
Which leaves us with a final thought. If the drug is literally you, how do you ever regulate it? How do you ever standardize it?
That's the question that's going to define the next decade of orthopedics.
Elton, we really hope this gives you the clarity you need to navigate all this. Be patient with that hip and definitely ask your doctor about that platelet activation issue.
And good luck with the rehab, Elton. Slow and steady is the way.
That's all for this deep dive. We'll catch you on the next one.